Thank you, Mr. Chairman. I'd like to thank the organizing committee and Professor Ayman Rifai for his kind invitation to be part of annual congress of ASNET. Today I will talk about renal changes during pregnancy through the following agenda: structural changes, systemic changes, changes in renal hemodynamics, renal tubular function alterations, and impact on fetal programming. Substantial structural and functional changes take place as a maternal adaptation to normal pregnancy. The pregnancy is considered a state of normal temporary norm due to alteration in kidney structure, renal hemodynamics and tubular function, volume and osmoregulation, and acid-base and electrolytes homeostasis alterations. It is important to understand the different changes during pregnancy to distinguish normal from compromised pregnancies. Regarding structural changes in pregnancy, there is increase in bipolar diameter of the kidney. Up to 26 weeks of gestation, it reaches 1 to 1.5 centimeters. Then it regains its actual size 3 to 6 months postpartum. This is partly due to increase in kidney volume up to 30% because of increments in both vascular and interstitial fluid compartment, and also due to physiological hydronephrosis with right-sided preponderance, which mainly due to mechanical compression by the enlarging uterus, and to a lesser extent by smooth muscle relaxing effect of progesterone. This leads to urinary stasis that may make the pregnant woman with asymptomatic bacteriuria at high risk of developing acute pyelonephritis. And this picture showing bilateral hydronephrosis with, which is mainly manifested on the right side. The right side predominance is due to that right ureter crosses the iliac and ovarian vessels at more acute angle than left ureter. The gold standard for evaluation of hydronephrosis during pregnancy is renal ultrasound, and this is done in this study with follow-up of renal ultrasound during pregnancy and for 3 months postpartum to diagnose the hydronephrosis incidence and the prevalence in pregnant women. And the threshold for development of hydronephrosis was at 20 weeks of gestation, with maximal incidence at 28 weeks and overall incidence was 63%. The physiologic proteinuria occurs during gestation and reaching up to 250 milligram per day. It is partly due to hyperfiltration and increase in glomerular membrane pore size and permeability, as well as alterations in proximal tubular function. And the pathological proteinuria set point was more than 300 milligram per day. In this study, the effect of type of pregnancy was investigated on the protein creatine ratio in singleton and twin pregnancies, with increase in protein excretion in twin pregnancies reaching 220 milligram per gram, and in singleton 150 milligram per gram at 34 to 38 weeks of gestation. In studies that concerning the mechanisms of development of proteinuria in preeclampsia, soluble anti-angiogenic factors from ischemic placenta were noted that to be injurious to vascular endothelium and causing disruption of slit diaphragm. And this balance between angiogenic and anti-angiogenic factors manifested also in healthy pregnancies. The soluble FMS-like tyrosine kinase 1 is one of anti-angiogenic factors that binds placental growth factor and vascular endothelial growth factor, preventing them from interaction with vascular endothelial cell receptor. So this leads to endothelial dysfunction and glomerular endotheliosis with decrease in GFR and the development of pathological proteinuria. The presence of glomerular endotheliosis was investigated in normal pregnancies, beside pregnancies with hypertension, either gestational hypertension or hypertension or pregnancies with preeclampsia. And from 12 healthy volunteers, renal biopsy taken in third trimester, 5 out of 12, there was some degree of glomerular endotheliosis, and to a higher extent in gestational hypertension and preeclampsia, with higher degree of glomerular endotheliosis in preeclampsia, and they concluded that preeclampsia may be the extreme of adaptational process rather than a separate abnormal condition. Regarding systemic changes, early in pregnancy, plasma osmolarity decreases by 10 milliosmol per kg below the non-pregnant norm because there is a reduction in serum sodium and associated anions. And to recognize this reduction in plasma osmolarity and expanded plasma volume as normal, 3 changes take place to preserve this expanded state of plasma. The osmotic threshold for antidiuretic hormone decreases, so the antidiuretic hormone will not suppressed by the increased plasma volume. The threshold for thirst will also decrease, so encouraging the drinking of water, and plasma volume status as a non-osmotic determinant of antidiuretic hormone is also reset to a higher level. The human choriogonadotropin, through releasing the relaxin, may have a role in reduction of osmotic threshold for antidiuretic hormone. Despite there is a high metabolic clearance of antidiuretic hormone during pregnancy, which reaches 4 times at week 10 through pregnancy due to secretion of placental vasopressinase enzyme. It is antagonized by increase in secretion of antidiuretic hormone, so its serum level kept normal. The increase in plasma volume reaching at the end of pregnancy up to 1.2 to 1.6 liters. This takes place progressively up to 32 to 34 weeks. The increase in plasma renin, angiotensin, aldosterone activity suggests that there is an underfill signal due to peripheral vasodilatation that leads to renal sodium and water retention. Also, tubuloglomerular feedback system, which normally suppressed during normal pregnancy, during normal states, non-pregnant states by volume expansion. In normal pregnancy, it is reset to recognize this expanded plasma volume and increase in GFR as normal, so it is not suppressed. And this was studied in this animal model study by micropuncture and microperfusion techniques. And they concluded that the renal proximal tubule perfusion rate was reset for a higher value for single nephron glomerular filtration rate, and the kidney does not sense this volume expansion as a stimulus to suppress feedback activity. Regarding endocrinal changes, the kidney is involved in endocrinal changes during pregnancy, either by synthesis of hormones or renal response to several hormones, including progesterone. Early on luteal phase, progesterone plays a role in increasing renal plasma flow and glomerular filtration rate, and this may continue during pregnancy. Renin, angiotensin, aldosterone system is activated during pregnancy due to increased renin production by renal and extrarenal sources like ovaries or deciduum, and angiotensin production by liver increases also during pregnancy under the influence of estrogen. Despite this increase in the activity, vasodilatation takes place during pregnancy. This is due to refractoriness to angiotensin 2 that is caused by progesterone and vascular endothelial growth factor mediated prostacycle increase, and also angiotensin 2 receptors type 1 are less responsive during normal pregnancy. Relaxin is produced by corpus luteum, deciduum, and placenta during pregnancy, and also implicated in increase in renal plasma flow, glomerular filtration rate, and afferent and efferent vasodilatation through nitric oxide dependent vasodilatation. This figure shows the degree of elevation of hormonal level during pregnancy weeks, with peak of secretion of human choriogonadotropin and relaxin in the first trimester, and peak of secretion of estradiol and progesterone in the third trimester. Regarding erythropoietin secretion, gestational increase in plasma volume in pregnancy are proportionally higher than increase in red blood cell mass, so there is hemodilution. So the normal hemoglobin level reset to 10.5 to 11 milligram per deciliter with reduction in hematocrit value. So the erythropoietin concentration also increases approximately 2-fold during pregnancy. Serum calcitriol level also increased 3-fold higher in the first trimester and 5 to 6 times higher in the third trimester. Regarding systemic hemodynamics, cardiac output significantly increases by 5th gestational week. It reaches up to 50% above the normal value at 26 weeks of gestation, and also heart rate increases up to 20% at 5th week of gestation, and stroke volume increases 20% to 30% by the 8th week. The pregnancy is considered a state of profound physiological vasodilatation with mediators like progesterone, nitric oxide, and prostaglandins that lead to decrease in systemic vascular resistance, and as a result, there is a reduction 5 to 10 millimeter mercury in blood pressure during pregnancy, and also organ blood flow increases in pregnancy, mainly for the kidneys and the skin throughout the gestation, and for the uterus in the second part of pregnancy. Pregnancy characterized by increments in total body electrolyte store, albeit with decrements in serum levels because of greater retention of water. So despite this increase in sodium during pregnancy by 3 to 4 milliequivalent per day, and with net balance of 900 to 1000 milliequivalent by end of gestation, there will be decrease in serum level by 4 milliequivalent per liter during pregnancy. And this is due to a complex interplay between natriuretic and anti-natriuretic factors. Natriuretic factors include increased glomerular filtration rate, atrial natriuretic peptide, progesterone, nitric oxide, prostaglandins, which counteracted by anti-natriuretic mechanisms, including aldosterone, angiotensin II, estrogen, the exocorticosterone, which is produced by extra-adrenal hydroxylation of progesterone, and increased in number of sodium-potassium transporters. Progesterone attenuates sodium reabsorption by competitively inhibiting aldosterone at the mineralocorticoid receptors, and also other factors that promote natriuresis include decrease in serum albumin and increase in prostaglandins and the melanocyte-stimulating hormone. Regarding potassium homeostasis, total body potassium stores also increases up to 320 milliequivalent by the end of gestation, but its serum level decreases by 0.25 milliequivalent per liter due to hemodilution, and the decrease in potassium excretion occurs despite the high aldosterone values because anti-mineralocorticoid effect of progesterone. Renal hemodynamics, including increase in glomerular filtration rate during pregnancy that reaches up to 50% above baseline at 26 weeks, and this fall to 30% above the baseline at the end of gestation. Also, renal blood flow increases up to 80% above the baseline at second trimester, and decreases to the non-pregnant normal value at the end of gestation. And the glomerular filtration rate continues to be elevated after delivery and normalize 4 to 6 weeks after delivery. There are 3 determinants that affecting the glomerular filtration rate called dynamic determinants of glomerular filtration rate, including hydraulic pressure gradient between glomerular capillary and the Bowman's capsule, oncotic pressure of the glomerular capillary, and glomerular ultrafiltration coefficient, which depends on surface area and permeability of the filtration of the membrane. These 3 forces affect the glomerular filtration rate by increase during pregnancy through decreasing the oncotic pressure and increase in hydraulic pressure gradient and increase in ultrafiltration coefficient at different stages of pregnancy. And even after pregnancy during postpartum period, GFR was noted to be elevated due to increase in hydrostatic pressure gradient up to 60% and 50% increase in ultrafiltration coefficient. On the other hand, several studies were noted that there is no increase in hydraulic pressure gradient in pregnant women. Also, increase in renal blood flow increases glomerular filtration rate and decreases oncotic pressure, and the tubuloglomerular feedback reset allow the higher increase in GFR. This is change in GFR and renal plasma flow, leading to decreased serum creatinine to 0.4 to 0.5 milligram per deciliter, and blood urea nitrogen to 8 to 10 milligram per deciliter. And the GFR formula cannot be relied on during pregnancy because they tend to underestimate glomerular filtration rate, and instead of this, we depend on the serial monitoring of serum creatinine level during pregnancy. Relaxin and the nitric oxide and the progesterone mediate renal vasodilatation and the glomerular hyperfiltration. The relaxin mediates this effect through matrix metalloproteinase 2 and endothelin receptor type B, leading to nitric oxide vasodilation. This study investigated the effect of relaxin in males and non-pregnant female rats through administration of relaxin. This produced physiological changes mimicked the normal pregnancy, including decrease in systemic vascular resistance and increase in renal plasma flow and glomerular filtration rate. And on the other hand, elimination of relaxin by ovarectomy or administration of monoclonal antibodies lead to disappearance of these manifestations of renal hemodynamic increase. And also in these two studies, acute and chronic inhibition of nitric oxide synthase decreased the nitric oxide production and lead to abolishment of glomerular hyperfiltration in pregnancy. On the other hand, the human studies, the existing data were less conclusive regarding relaxin and nitric oxide role in pregnancy. In this study, the recombinant human relaxin effect was investigated in healthy volunteers, non-pregnant females and males through administration of recombinant relaxin. This increased the renal plasma flow to 47%, but there were no changes in GFR. Also regarding the comparison between nitric oxide level and its metabolites in preeclampsia and normal pregnancies, nitric oxide production increased in normal pregnancies and decreased in preeclampsia, and the nitric oxide metabolites maintained elevated even after the delivery. Regarding renal tubular function alterations, the renal handling of several metabolites and solutes altered during pregnancy depending on changes in excretion and reabsorption. Glycosuria frequently occurs during pregnancy and reflects reduced tubular reabsorption without metabolic disturbance. This is partly due to decrease in the maximum transport capacity, mostly in the proximal tubule, and also due to inability of renal tubules to cope with the increased filtered glucose load. Calcium excretion also increases 2 to 3 times during pregnancy because of increased filtered load, and also simultaneous increase in urinary acidic glycoproteins, magnesium citrate, nephrocalcine. This inhibits formation of calcium oxalate calculi. Uric acid reabsorption decreased during pregnancy, and this leads to its serum level decreased to 2 to 3 milligram per deciliter in the first trimester, and this normalizes at the end of pregnancy. This is due to high renal clearance due to increased production of fetal and placental growth, and it is a diagnostic value in preeclampsia because it is increased in preeclampsia due to decreased renal clearance and increased its production by trophoblast breakdown. Hyperventilation in pregnancy causes mild chronic respiratory alkalosis with secondary compensatory mild metabolic acidosis due to decrease in bicarbonate and increased its excretion. Also, amino acid and vitamins increased excretion during pregnancy, especially nicotinic acid and ascorbic acid and folic acid and many amino acids. Significant proteinuria should not only be attributed to hyperfiltration and increase in glomerular filtration rate, also impaired tubular reabsorption contribute to the generation of proteinuria, which is notable after 20 weeks of gestation. The protein content in urine, mostly Tamhorse-Fall protein and small amount of albumin and other circulating proteins. Previously mentioned changes, including cardiovascular changes, endocrinal changes, and changes in glomerular hemodynamics and tubular reabsorption. This lead to development of proteinuria through increase in renal plasma flow and increase in GFR, decrease in tubular reabsorption capacity, and endocellulosis. Impact of these changes on fetal programming: women with normal pregnancy who have suboptimal increases in plasma volume are more likely to have fetal growth restriction and preterm delivery. This can program the offspring for adult life, increased risk of hypertension, diabetes, hypercholesterolemia, and also chronic kidney disease due to decrease in the number of nephron. Take-home message: the precise orchestration of hemodynamic changes and the balance of fluid and electrolytes are essential to development and the maintenance of successful pregnancy for mother and child. The volume sensing and regulatory systems are dramatically readjusted throughout pregnancy to accommodate and maintain the volume expansion. The sum effect of volume expansion increases in cardiac output, pulse rate, and reduced systemic vascular resistance and the blood pressure, in renal vasodilatation, and increased in renal plasma flow and glomerular filtration rate. The knowledge of anatomical, physiological, and biochemical values of these alterations permits earlier detection and facilitates management of renal disease and hypertension during pregnancy, and this table summarizes all the numbers of changes that happens during normal pregnancy. Thank you.